Okay, great. So let's get started. Thank you everybody for coming. Just just a warning, everything that we're going to say is going to be, I'm going to post it to YouTube. So keep all comments PG, especially you, Cammie. You kind of get wild with these things. So none of those wild comments, okay? Because it's on the video. Everything's on the internet these days.
Okay.
So thanks for coming.
You want me to duct tape?
No, don't duct tape her. She'll ruin her makeup. She looks so good. It takes a long time for her to get ready. So I'm just kidding. So thanks everybody for coming. So just let's talk about the spine. So the spine, I thought this was really interesting. It kind of shows you where the spine is in people, and it's a column. It's something to always remember. There are many bones. They're all separate yet connected. They all move separately. They're all connected, and it's a column. There's a column of cubes. So just think of a big column full of cubes. That's what the spine is made of. So here again is the column. You can see all the cubes stacked up, and in between each bone or cube is a disc, a soft material, which is cartilaginous, and we call it a disc. And it looks a little bit like a disc, or maybe like a hockey puck. And the old guy on the left, that's Verbeest. He was the first neurosurgeon who helped us understand that low back pain can be caused by neurological compression, and by decompressing the spine, it helps people with their pain. And so, we didn't always know this in the history of mankind. It was new, and he was sort of a pioneer for us in spine. And the guy on the left was Mixter, and he wrote an article, I think it was 1931, in the New England Journal of Medicine, that decompressing and doing discectomy helps people resolve their sciatica type pain. And now we already know, everybody knows that the spine's a column, right? We just said that. And they're separate bones. And each bone, in each bone, there's a tube. So you can see how there's a tube right there. And if you stack all these tubes up, that makes up the spinal canal. So I think everybody understands the spinal canal, right? And if the tube gets tight, like here's the tube here, if this tube gets tight from either disc material in the back or extra ligamentous material, you get spinal stenosis and you get compression of the nerves. So this is an axial cut through this same level. And you can see there's very little room for the nerves here. Now, if you look at the spinal canal all the way down, on the front view the spine is straight. On the side view it has a gentle curvature. So this is where the buttocks would be. This is the small of the back. This is the thoracic spine. This is the neck. And this is what the spinal canal looks like. And at every level it has a different shape. So here it's at its biggest in the foramen magnum, or at the top, at the base of the brain. And then as you go down, it gets smaller. But it always should be somewhat circular. You see in the thoracic spine, it's very circular. And then in the lumbar spine, it's mostly circular, but it can become triangular. But it has certain types of shapes. And in the nerves, good morning, Doug, thanks for coming. The nerves need a certain amount of room. This is a graph from Rene, I forget his last name now. But he had a article. He had a book on spine, and the anterior posterior diameter of the spinal canal needs to be a certain size in most people, and it's somewhere between about 15 millimeters. This is the mean. This is the range. So it's around 15 by about 20 millimeters. That's how much you need in your spinal canal. If you don't have that, you have stenosis. The other important thing to know is the spine grows right here at the junction of the pedicle and the vertebral body. Here's the spinal canal. And some people are born with a small spinal canal. They're born with a small tube. And if you're born with a small spinal canal, or you can call it congenital stenosis, you can call it developmental stenosis, you can imagine if you have a small tube to begin with, if something happens, you have no room. And then that becomes symptomatic very quickly. So some people have big tubes, or spinal canal, some people have small ones. And the nerves, here's the spinal canal, the nerves are housed in the spinal canal, so if the nerves are compressed, it's a problem. This just shows you the anatomy within the spinal canal. In the cervical and thoracic spine is where the spinal cord is, and then around L1, L2, and 85% of people it ends, and below that is just nerve roots. And you can see at every level a nerve exits the spinal cord or the thecal sac below the pedicle. This just shows you it's the same thing at the base. So I'm not sure if we're going to go over this. This is an 81-year-old man with low back pain, a retired carpenter, big guy, 6 feet, 220 pounds, and these are his x-rays. He has what looks to be diffuse idiopathic skeletal hyperostosis. See all these big osteophytes? Now, in the history, we usually ask people, what brings you here? It's usually pain in the buttocks and legs, and usually posterior because it's sacral L5 nerve roots. And the other thing is, if you go to, where do you go grocery shopping, Doug? Do you go to the Falston Walmart?
Absolutely.
If you go to the Falston Walmart and go grocery shopping, that's where I go. You see all these people leaning forwards on their carts.
That's why you go there, right?
Yeah, they're nice. They're nice women. That's the only women that talk to me now. Everybody else thinks I'm creepy. So the women lean forward on their carts. And there's a reason for this, is because when you lean forwards, you stretch the ligamentum flavum. If you lean backwards, it buckles. So you can see if this buckled, it would compress more into the nerve roots. But if it's stretched, it gives the spinal canal more room. So that's why when people have spinal stenosis, they lean forward on their grocery carts because it helps with their back. Everybody understand that? The other way that you can get stenosis is from the facets. So where the two bones come together in the spine, that's called the facet. And if it overgrows, if you have an osteophyte, like I have an osteophyte in my thumb at the MP joint from trauma, or maybe it's just arthritis that I was born with. But when everybody gets older, they always say they have arthritis because they play sports, because they want to be robust people. They don't like to say because I'm old. But is that right? Right, Doug? So here's my osteophyte. And if you get an osteophyte in the facet, it compresses the nerves. So this is another area. So the disc can go backwards, the ligamentum flavum that connects the two lamina can cause it, and also the facet. These are 3 areas. And there are other things that can cause leg pain and low back pain. Ischemia, vascular ischemia, which I always miss because I'm not a vascular surgeon. This is an obvious case, but sometimes it's not obvious at all. Doug, has anybody ever presented to you with vascular ischemia and you've been fooled, or?
Yes.
Would you have any rules of thumb, or how do you do it? Feel pulses, or ask if they smoke cigarettes?
Yeah, I always try to feel pulses.
It's not easy
The
sometimes.
ones that fool me are like the young guys that you don't think are, are smokers, but they have some kind of, vascular disease that wouldn't be obvious. Usually smokers, when they come in, you can sort of, smell them when they walk in, and it's pretty evident from other stuff.
Yeah, you can smell cigarette smoke, yeah, but sometimes you can't. So I've definitely been fooled many times with vascular ischemia. And the ischemia can be acute, too. It can be very painful. So if you extend your back, that should make the pain in the back worse if it's spinal stenosis, because it buckles the ligamentum flavum. So the things that you should not ignore as a clinician are pain at night. Any kind of night pain can be a serious problem, because during the day you don't feel things because you're thinking about other things, like you're thinking about work or home, or your kids are driving you crazy, or you're looking at beautiful women or something, or you're a creepy dude or something's on your mind. But at night, if you're at rest, that's when pain comes through, bone pain. Other things, pain at rest is very unusual. Progressive neurological deficit is a serious problem, needs to be evaluated. Or if you have a suspicion of cancer or an infection. And risk for infection, who can name some risks for infection? Doug, what?
Steroids?
Steroid users, like rheumatoid arthritis, definitely. How about diabetics, IV drug abusers? Any IV drug abuser with back pain, I always think of an epidural abscess. And the other thing is a person with cancer. It could be a presentation of cancer, of a met to the spine. Other things are weight loss and constitutional problems. Other things that can cause pain, and can complicate things are fear, anxiety, financial problems, anger, depression. You have to look at the person as a human being first, and not as an anatomical specimen. And this is just how to diagnose depression: a depressed mood and loss of interest, weight loss, weight gain, insomnia, hyperinsomnia, agitation. I always keep this list, and if I have someone who's seriously depressed, I hand it to the patient. I was like, do you think you have these things? I'm not a psychiatrist, obviously. And
They thought it was low T.
Huh?
They thought it was low T. TV commercials, right?
Yeah. So I keep forgetting it.
Jill.
Jill. So have you ever seen someone with back pain and it was not from? You're in urgent care, so you probably see things sometimes.
Of course, I mean.
That's not
urinary
spine.
tract, I mean, everybody comes with
Urinary tract infection.
Yeah, that's a big one for us.
Yeah, urosepsis or a kidney infection.
Yes.
Pyelonephritis. Other things. Have you ever seen an aortic aneurysm? I had a young woman. Have you?
I have. I mean, when I did
Present as
my
back
ER
pain?
days, I haven't in the urgent care center, but when I did the ER days.
I had a woman walk into my office, 25 years old, with an aortic aneurysm and back pain. Yeah, and I saw it on the MRI. I was like, oh my god! And she had a familial predisposition to getting an aortic aneurysm, so it's possible. But
this is a 31-year-old girl that died.
yeah, it's rare, but it's possible. Other things, sacroiliac joint infections. Have you ever guys diagnosed that? I had a woman who had hyperparathyroidism and I had sacroiliitis from hyperparathyroidism, and I diagnosed it. I didn't diagnose it. The radiologist said that the SI joint was loosened, and that was the cause of her pain. And then we treated the hyperparathyroidism, and she got better.
So like a brown tumor?
They get sacroiliitis. It wasn't a brown tumor. They get sacroiliitis. I don't know why. Menstrual period, pregnancy. I've never diagnosed that. So what's Cauda equina syndrome? That's something that's very serious that you have to always rule out. Cauda equina syndrome is a constellation of three things. So one is, does anybody want to describe it? Or one is severe back pain and leg pain. The next one is perineal anesthesia or saddle anesthesia. And back pain, saddle anesthesia. And the third one, what's that? Bowel bladder dysfunction. And it may not just be incontinence, it also could be retention, which is like, you can't diagnose that. And in the ER, you guys stick Foley's in, and all of a sudden you get 600 cc's, which is, something's wrong. So and you may say, what's saddle anesthesia? Well, let's say, Doug, on Friday night you get really drunk, and you jump on your horse, and you paint this naked, and you paint the saddle, and then you look where the paint is. That's the saddle anesthesia that these patients get. So it's a sacral nerve root saddle anesthesia. So you paint a saddle, you jump on it naked, you get off and look where the pain is. That's saddle anesthesia. So unfortunately, it's something that people don't tell you. They're embarrassed, or the last thing you want is someone poking around your perineum. And that's why I don't go to my primary care physician. I'm worried he's going to do a rectal exam. So they don't tell you this. So you have to ask, do you have perineal anesthesia? Is your vaginal area, scrotum area numb? And if they do, it's a serious problem. And you can see here the sacral nerve roots are all in the perineal area. So they get numb. And the other thing you can do is see if a motor exam of the bladder is do a bladder scan and see if they have a massive bladder. And they also do a post-void residual to see, how well the bladder empties. That's another way you can do it. Does anybody have any other ways to diagnose Cauda equina syndrome or bowel bladder dysfunction? Send them me. Well, I'm not at that. So how do you treat lumbar stenosis? You can take steroids, ibuprofen. This is a picture of Doug when he was in college. Ibuprofen medicines, amitriptyline, which is antidepressant medicines, muscle relaxers. You can do. The problem with nonsteroidals is they cause gastric bleeds, renal failure, hypertension, and everybody knows from Vioxx is that you can get heart attacks from this. And this is the FDA's statement that physicians are encouraged to carefully weigh the potential benefits and risks of nonsteroidals and other treatments for the condition to be treated before a decision is made to be placed on an NSAID. If chronic use of NSAID is selected for an individual patient, the lowest effective dose for the shortest duration consistent with the individual patient treatment goals should be used. Nonsteroidals should not be used in patients who are immediately post-operative from cabbage surgery. So the problem is when people have pain, they want the highest dose for the longest time. I mean, they don't want the shortest dose for the smallest dose for the shortest time. So what do you do do you give out ibuprofen medicines?
Yes.
Do you who do you not give it to? Cabbage patients, obviously.
People with obviously history of a GI bleed.
GI bleed. How about if patients have a history of a cabbage in the remote past, or a cardiac history, or coronary artery disease, or have had stents, or I'm always worried.
I'm not.
You just give it?
Yep.
Okay.
I think that I mean, that's almost half the population, people have coronary artery disease.
That
So
we
I think-
see, yeah.
And I think that was sort of, that was just the COX-2 that were sort of tagged with that, but then they went back and they, sort of, if they compared it, that's why Celebrex is on now, because they say it's no difference from naproxen.
Uh-huh.
I always thought it was just the opposite. I thought I saved 1 million people from dying by giving them ibuprofen because they didn't get a DVT. I mean, it does have platelet inhibitory activity,
Uh-huh.
but I think it was just in the recent past cabbage,
Uh-huh.
and I don't think they've defined
Immediate
how,
post-op,
how
immediate post-op.
recent it is. Yeah,
Yeah.
a month or something like that.
Yeah.
But that's one thing for a prescription is supposed to have 4 things on it, a proper prescription, and one of them is there's supposed to be an end date for medicine that you give them.
Uh-huh.
So if you give them like ibuprofen or something, it's
I
not
never
supposed
do that.
I know.
So how do you put it on?
Hardly anyone does, but well, I think pharmacies are getting around it now by putting expiration dates on some of the med. But you're supposed to say, take for 10 days. You're supposed to say, you're supposed to put a time limit on it. You're not supposed to say like ibuprofen twice a day.
That's a good idea. You should put
600 with 10 refills.
You should put 2 months supply.
There's supposed to be an end date on it, because just like this recommendation, you're supposed to put a time course on it. 'Cause
Right.
supposedly people, that's how they abuse it. They give me a prescription, I can take it for whatever I want.
Forever, right. Actually, that's a good idea. Okay, other treatments are rest, therapy. Rob, what are your therapy recommendations for lumbar stenosis?
Usually, as you see in the video up there, the pictures, we try to strengthen up the core a little bit, do some...
What does this guy do? Is he choking the man from
I
behind?
have no idea what's going on there.
Okay.
Especially if it's...
This looks a little bit weird too. What is this?
Yeah.
Megan, is this what you do to people? If so, I'm going to start going to therapy. What is this?
They look like they're doing some stabilization.
Stabilization?
On the ball.
Yeah,
So
it's kind of a
for
new,
stenosis.
new type of...
Looks
patient,
interesting.
isn't it?
Looks interesting.
He lost his license, that's what happened.
This person lost his life. How about this? What is this? So just for the neck strengthening.
I have never seen
How about the
this.
traction? Do you guys supply traction?
I usually don't give that traction unit. I don't like that one because I think it puts too much pressure on the jaw if I'm doing like a home traction unit. Saunders has a much better one out there, which is a supine unit, and it's a lot more expensive, and insurances will cover it most of the time.
What's wrong with this one on the bottom?
Puts a lot of pressure through the TMJ. You
Yeah.
get some...
That?
yeah.
Mhm.
Has TMJ problems.
Yeah, I tell patients that I can put a rope around your head and pull on it. That may help.
But
They all laugh, but they all like it too, though.
I mean, traction is very effective for
Mhm.
people, and they can get pretty immediate relief, so
Mhm.
they like it. Conservative.
Okay. All right. So imaging,
How about a cervical collar?
soft cervical collar.
Yeah.
Sure, that's a good idea. I usually tell people to wear it at night because I want people to not be patients, but rather be like human beings with a problem and not sort of focus on the disease process. So I try to limit collars in that sense. But collars help, especially at night. They can rest the neck. Okay, so let's do a case. Interesting cases are always good. So this is a 77-year-old woman with left leg pain, severe low back pain, and I had done her previous surgery, so unfortunately she's a failure of mine. I decompressed her from L2 to L4, an laminar foraminotomy decompression. It presents with recurrent pain, and I gave her pain pills, steroids. She wasn't getting better, so I ordered a new MRI scan. So does anybody want to comment what they see here on these sagittal cuts?
I can point that.
What is it, Nate? What is it?
I'm not sure that level, but is that L304?
Yeah, L304. What do you see?
Okay, so she has a large disc that's protruding into the spinal canal.
Yeah.
It's compressing the nerve elements. There's
Huge
loss
disc
of
into the spinal canal.
fat. There's a little bit of edema.
Yeah, here are the nerves. Yeah, so it's obvious, really big recurrent disc herniation. Now this is what the spinal canal should look like. Remember the two we talked about? Here are the neurological elements, and this is at level 5, 4, 3, 2, 1, L1, L2. So it should look like this all the way down. And here we are at the level that Doug described. And what do you see here, Doug? The central.
Yeah, I see
Central.
central bulging. It looks like there's some compression in the AP plane.
So here are the nerves. So all the white stuff was fluid around the nerve. See how the nerves are compressed there? So she has central stenosis from a large disc herniation. And you can imagine if you have a small spinal canal to begin with, if you have something like this, it's a problem. And now, does anyone know why we, in revisions, we do dye? We give gadolinium dye because the vascular areas, it lights it up. So sometimes you can have compression of the nerves just from scar. And the dye lights up the scar. So here's, look in this case, see here's the scar from the previous surgery. But this is not scar, this is a big new disc. So whenever people have revisions, you need to give gadolinium dye to know whether it's a scar or if it's a new disc. And here's the gadolinium dye, you can still see the disc. But if it was a scar, the disc would go away and you would just see white scar. It would just be white here. So that's why recurrent discs. Okay, so now let's go to the videotape. So she failed non-operative measures, and she was miserable, and she wanted surgery. So this is the, we have a beautiful Leica microscope that gives us high definition video. And I know everyone's like, what is going on? Where are we? This is a suction, okay? I've already removed the bone from the spinal canal, and I'm flushing out. I have a, actually, I don't want to show this yet. Hold on. That's the finale. I want to show the approach so you guys understand. Okay, so this is the thecal sac, and this is a Kerrison punch. And has anybody here seen a Kerrison punch before? I have one right here for everybody. So can you turn on the lights for a second? So this is a Kerrison punch. Kerrison punch is a great instrument. It's got this curved foot, and it's got a punch, and you can bite things from the spinal canal and remove bone material. So can you turn on the lights? I'm going to pass it around. So it's a great instrument for decompressing the spinal canal. Can you turn the lights back down? So this is a suction tip, and that's just a high-speed burn. I'm removing bone from the area of the spine, and this is a thecal sac right here, and we do this under magnification. This is a retractor, and this is her bone, and we thin down and we try to get down to the nerve so we can decompress. And the yellow thing is the yellow ligament, or the ligamentum flavum, and it's the ligamentum flavum is compressing your nerves as well. So we have to remove that ligamentum flavum, and this is the dura, or the thecal sac. That's a curette. And this is a revision case, so it's difficult. So everything's scarred. So I have to go really slow not to get a spinal fluid leak. The nerves are covered like in a bag of fluid. So you see the Kerrison punch picks away at this ligamentum flavum to expose the nerve roots in the bone. Kind of gives you an idea of what we do. And I'm removing more and more. So now you can see the thecal sac well, right? Here are the nerves. And hey, Joanne, good morning. Come on in. And this is the thecal sac, and it looks like a white balloon, basically. And inside of the nerve roots and the spinal fluid. And in the lumbar spine, you can push on it, and obviously you can't push on it higher up because it's spinal cord. And I'm teasing away the scar to get down to the disc to expose it. So you have to be careful, because if you cut the dura, it can leak spinal fluid, and then it's a real mess, because then the dura and the nerves, you can't see them anymore. It's like deflating a balloon of water. So it's really hard to differentiate the anatomy once you get a spinal fluid leak. I mean, it's doable, but it's a lot more difficult. So you want to be careful. Also, it's not good to have a spinal fluid leak for obvious reasons. You have to repair it. So you see, I'm trying to tease away all the scar to get down to the disc. Does anybody have any questions about that? See how I'm getting farther? You got to be patient with this, farther and farther. And the problem is, you have to be really patient, but your assistant gets really angry because he's bored, so Eric's always yelling at me, come on, hurry up, come on, let's get this case over with. Okay, so once you expose the disc, hold on, where's big disc fragment? So you remove the disc with a pituitary rongeur, and then once you get a hole, I put a catheter, a pediatric suction catheter. This is a neurosurgeon taught me this trick, and I flush out the disc, and sometimes you can get the fragment just to come out on its own. So you kind of coax it out by flushing it out. And see the little disc fragment there? So I'm flushing inside of the disc space itself. Eric's actually doing the flushing, and it can flush out the fragment. See, there's a huge fragment. And let me show you what it looks like. It kind of looks like crab meat because we're Marylanders. See how it kind of looks like crab meat? And that's like a very large fragment that we flushed out of the spinal canal, and that's a pituitary that pulls it out. See the pituitary instrument? Let me show you guys. Can you turn the lights on for a second? This is a pituitary, so you guys know what it looks like. It's made to go in your, like, just above your gum line and pull out the pituitary gland. So it's a really long grabbing instrument, and just grabs stuff and pulls it out. So pass it around to you guys. So we use the, can you turn the lights back on? Use the pituitary rongeur to pull out disc fragments. And you see this is a plastic soft sucker. I prefer using the plastic soft sucker. And then the pituitary pulls out the disc material. But the disc material usually doesn't come out in one solid piece like last time. That, like you saw, it usually comes out in very small pieces, and it's adherent. So you see how you have to keep eating at it with the pituitary, and the pituitary is rounded, so you don't injure the dura. So here's the disc hole where the disc came out, and we're decompressing the spine now. And this is a pituitary. This is a Penfield 4 that teases the disc fragments away from the dura and pulls it out so you can pull it out. So it kind of shows you what the decompression is like. And this is these are the nerves again, the thecal sac. So any questions about that? Let me see if there's anything else kind of interesting. The rest is just more the same. It's just constant probing and seeing if there's any. You don't want to leave something in there either, because then the patient will have persistent symptoms. So it's the case is constant probing and feeling and removing, probing, feeling, and removing until you're confident that. See how there's more disc material there, but it's adherence. The case continues until you're confident that there's nothing that remains within the spinal canal that's still compressing the nerves that could cause persistent pain. And the other thing is, like, you don't want to leave disc material within the disc space that's loose, because then it'll come out in the immediate postoperative period and cause more problems. So it's a judgment call as to how much disc material to remove. And you can see it's not obvious what you should leave and what you should remove sometimes, right? So sometimes you never know when you're done. And you can't remove all the disc material. I mean, that used to be the standard of care, but then people will get horrible back pain afterwards because they had no shock absorber to their spine. So it's like sort of like a judgment call. So any questions about that? About discectomy? All right. So let's maybe do some other cases. Okay, here's actually let's skip this case. Well, we can do this case. It's an 81-year-old man with left greater than right lower extremity pain, low back pain. He has a history of prostate cancer at age 44. He's a retired carpenter, very robust man, 6 feet, 220 pounds. So, Joanne, what do you see on these sagittal cuts? Since you came, you have to talk.
Thank you. So you have T2 images, and you have a lot of degenerative end plate changes, Schmorl's nose, particularly on the inferior end plate of L1 and L3, and ventral osteophytes as well. You have some posterior disc bulge.
What is a Schmoll node? So everybody knows. What is it?
Schmorl's nose is a herniation of disc through the central aspect of the end plate.
So this material goes in here,
Yeah.
and okay.
It's a concave deformity of the end plate.
Mm-hmm.
And they're quite common.
Mm-hmm.
And need to be distinguished from Mets, especially in a patient like this.
He has prostate cancer. Does he have Mets? Spine cancer?
From two images, it doesn't look probable.
Okay.
Being a radiologist, our hedge is our favorite bush.
Yeah, you guys are always like that. Just say probably not, but cannot rule out
Probably
anything.
not. So the Cauda equina is strange looking.
Yeah.
For no other great word.
It's compressed, and well, let's look some more pictures. This is kind of a weird picture. How about this one?
So at L3-4, you have the most prominent posterior extension of dark disc material, as well as probably hypertrophy of posterior elements, ligamentum flavum, and
Here's the ligament flavum right here, right?
yeah.
On the back side.
Right. So you have
So it's a double whammy. You got ligament flavum posteriorly, and you got disc anteriorly. You see that? Okay.
So,
That's pretty. I'm gonna keep moving if you don't mind.
yeah, no, absolutely.
So here's some axial cuts for you.
Axial images. So, most like the central image bottom, you see the most significant degree of central stenosis, which
Mhm.
again is caused by the excessive ventral broad-based disc osteophyte
Here's a
complex.
disc. Mm-hmm.
So we don't know what it is. It's all dark. So we just lump it into a general term, disc osteophyte complex, for lack of a better ability to describe it. And then
Okay.
we also have the ligament flavum, which is the dark V-shaped stuff in the back.
Here's the ligament flavum. It shouldn't be this big, right? It should be like thin here.
Exactly.
Yeah, see how big it is here? So it's high. Why is it hypertrophic? Do you have any idea?
My guess is that over time the facets have.
Is it a cancer? Is it a cancerous
No.
ligament flavum?
It's highly unlikely.
Why does ligament flavum get big? Does anybody know? I don't know.
I'm guessing it's degenerative. Kind of just built like a callus. Things are.
Well, callus is formed because it's pressure equals force over area. So if you increase the area, this is what orthopedics we say. If you increase the area of something, the pressure goes down. So if you have a lot of pressure on a joint, the body naturally increases the surface area to relieve the pressure. But ligamentum flavum doesn't work that way. Nobody really. There is some evidence that it could be like some kind of benign process within ligamentum flavum. Sort of like there's some. I mean, people have cultured it in vitro, but nobody knows. I'm just messing around to see if anybody has any idea. Okay.
So also within the ligament fluid, somewhat interestingly, you have two lines essentially of bright increased T2 signal, which may be some
This?
fluid. Yeah,
What's that?
I don't know. So maybe.
Why don't you guess? This is a conference.
I think it's some fluid extending from the facets. most
Yeah.
likely.
Yeah, so sometimes when we're doing these decompressions, and I'm removing ligament flavum, fluid comes out, and there it goes. Now you did it again. You have another spinal fluid leak, and I was like, no, it's not. It's just maybe some fluid from the joint. I'm just kidding. I'm just messing with Eric. Okay, so are these changes normal? This is from Bowden's article. If you're really old and you're older than 40. It's pretty common. 14% of people have foraminal stenosis. 34% of people have spurs. Your disc is narrowed, and none of these people had back pain ever in this study. So if you're over 40 years old and you're old, the chances are you've got degenerative changes. It doesn't necessarily mean it's causing you symptoms, but it's probably part of the natural aging process. And some people are born with short pedicles, like this guy. This guy has the pedicles should be long here. So you can imagine if they were longer, he'd have big spinal canal, but he has short pedicles, and his spinal canal is really small. You see that? It should be a lot bigger than that. We won't get into that. So the treatments, you can do a full laminectomy, removing the full lamina, and I'm going to pass around this model so you guys can see what lamina looks like. You can do an X-stop for these people. Does anybody here have any feelings about X-stop? Do you like them, Cammie? No?
No.
Okay, we won't talk about it. Huh?
Yeah, what's your opinion?
I can't get into it right now.
You're going to.
But, I mean, tell people what they're.
What did Nate say? They're very expensive? How expensive are they? Just to estimate. $5,000, right? Right.
But it's an FDA-approved device for one indication.
What?
Spinal stenosis, right?
Yeah.
Stenosis, that's the only indication for it.
Yeah. What are you putting it in for? Meniscal repairs?
MTP fusions, you name it, I mean.
Yeah.
The only insurance that allows it is Medicare.
Medicare.
Medicare? That's it?
Medicare's the only one that's really on par with it. All the others, you have to go through a
So basically what you do is you sort of, I mean, you're the spine surgeon, Spiro, but basically you sort of just jack this into the
Posterior
pelvis,
posterior
try to
spinous
jack it up a
processes.
little bit.
Yeah, you distract it a little bit. Just like the old lady bends over the grocery cart, she distracts her spine. You do that focally at the posterior spinous processes by distracting a little bit. And apparently it should help, but sometimes not.
In the German studies, they all got better.
Yeah, well, I don't want to get into it. So that's another topic. So you can do these porthole decompressions. That's how I used to do it. And this is my friend Chuck Edwards. He's actually a close personal friend of mine, my former partner. This is the way I usually do things now. Is I do a unilateral laminectomy and bilateral decompression by leaving most of the spine intact, but just going from one side and opening both sides of the spinal canal. You can see how you can do that. This is a full laminectomy, but then you remove the posterior spinous processes, weakens the spine. This is the porthole, which you have to expose both sides, so both sides of the spine muscle gets weak. But if you just go on one side, half the spine musculature stays intact. You can see how you can decompress a very tight spinal canal by just one side. It was sort of recently, it was first described in '95 in neurosurgery. This is another video. I have more cases. Do you guys want to go over more cases or see another video? More cases? Okay. This is, actually I got an interesting case of, let me go to the most interesting one and then we'll go backwards. This is a, for Eric this is boring because I show him the same stuff over and over again, but this is a 30-year-old man with low back pain for 6 months. And what do you see here, Joanne?
So you see two levels of abnormality. The largest,
Let's just focus on this one.
okay, so at L45,
Mhm.
a large disc bulge.
Mm-hmm.
It looks bulgy. I would classify it as bulge on
Mm-hmm.
this view, but sometimes if it's taller than wide, it's protrusion. So,
Okay.
based on its axial morphology.
Big bulge. How about the axial cut?
So there's
Here's the spinal canal above.
above.
What about here?
At is looking pretty stenotic.
Yeah, you can't see any spinal fluid around the nerve roots.